giving the name of the first author. Anybody from which one? Okay, you come. So, Anjali, dumbbell technique for iridodialysis repair. Dr. Anjali Khadia. So, you know the rules of the video, okay?
This is a competitive session, so be careful. You should not overstep the time because you can get your marks cut and try to at the end so that everybody can, learn from whatever you बताना पड़ेगा शायद.
One fine day, a resident is performing small incision cataract surgery. While doing nucleus delivery, there occurs a mishap. Oh no, I have an inferior iridodialysis. What should I do now? The case was managed by a consultant and iridodialysis was repaired.
Good morning, ma'am.
Good morning.
Ma'am, I
watch
had an
is not
iodopsis
running.
yesterday. Is it very hard to repair? Can I do it myself?
AVPC, the watch
It is not difficult.
running.
You can do it yourself, even as a beginner.
Me? Are you serious? I'm just starting out.
Do you go to the gym?
Yes.
Then you must have seen a dumbbell. We can use a dumbbell technique to repair the iridodialysis.
Dumbbell technique. What is that?
Sit, I will show you. This is the dumbbell technique, a simple yet effective way to repair iridodialysis using the ab interno approach. Iridodialysis can be seen from 3 to 8 o'clock hour. With the initial suture securing the iris root in place, let's take a closer look at how the suture was placed. A spatulated straight needle with 7O proline suture is introduced from the main incision parallel to the iris using needle holding forceps. This exits from the sclera approximately 1.5 mm from the nimbus at 6 o'clock position. The proximal suture is cut, then flanged with low temperature cautery, pulled towards 6 o'clock position. The distal end is also cut, leaving a stump of 1.5 cm. Next, in the same manner, now needle is introduced from 9 o'clock position. The needle is exteriorized at 3 o'clock position. Proximal end is cut, then flanged, gently pulled towards 3 o'clock position, and distal end is then cut. In the same way, another needle is inserted from 11 o'clock, exteriorized at 5 o'clock, and same procedure is repeated again. Now, all the distal end of the suture are gently pulled and tightened so that iris appears flat. All the distal ends are now flanged at the scleral end with the help of a low temperature cautery. The viscoelastic from the anterior chamber washed, anterior chamber is formed and conjunctiva is opposed with bipolar cautery. What we saw now was ab interno approach. Now let's see ab externo approach. Iridodialysis is noted 2 clock hours from 9 o'clock to 11 o'clock position. A spatulated straight needle with 7O proline suture is introduced 1.5 mm away from the limbus at 9 o'clock position. It is passed parallelly through the detached iris root part and externalized from the cornea at 3 o'clock position. The suture is cut and then pulled outside from the main incision with the help of a Coughlin iris hook. The externalized suture is flushed with the help of low temperature cautery. Now the other end is pulled out from 9 o'clock incision and iris is secured with the help of the flange. The external end is cut 1.5 mm length from the nimbus and flanged with the help of low temperature cautery.
I'm not very confident of using my non-dominant hand during surgery. Will it be a problem?
No, that will not be a problem. The surgeon can either choose ab externo or ab interno method according to his or her convenience. Let me simplify this for you. The right eye is divided in four quadrants. When iridodialysis occurs inferonasally, we can do the ab interno approach. If it occurs inferotemporally, we will prefer ab externo approach. For superotemporal, we will do ab externo approach. And lastly, for superonasal, ab externo approach is taken. In this procedure, there is no need for 26 gauge, 27 gauge or 30 gauge needles. Pre-flanges or knots are not required. We only need low temperature cautery and a 7-O-proline suture with spatulated single needle. The spatulated 7-O-proline needle makes a clean rectangular incision about 250 by 100 microns. In comparison, 26 gauge needle and 30 gauge needles create larger, irregular circular incisions nearly twice the size. Smaller flange size means less damage to the iris, Tenon's capsule and sclera. Plus, flange slippage rate is almost negligible. As a result, cleaner, safer and more precise outcomes. The best advantage of this technique is that it has a minimal learning curve. That being said, no technique is perfect. In this method, titration of tension is of utmost importance. Tension should not be too tight nor too loose. Don't fear complications. Learn the technique, practice under supervision, and soon you will handle iridodialysis with confidence.
Thank you.
It was very well in time, rather before time. How will you make sure about your knots that they are not going to spill? Because when you are putting it in inside, it was a very bigger in size. From outside, it was very small. So it may go in the knot you are cauterizing. How will we sure about that? Yes, this is the point that this dimension is not going, because inside it was a bigger, outside it was very small.
Uh, uh, Good question, sir. So knot, whatever is the very minute knot is there, that is 200 to 200 microns like that. So when we were doing that, this knot is there. No, this is just the iris is small layer is there, epithelium stromal. That is the hook in the iris. And when outside also same measurement is there. So when tightening is very important during the tightening. So like SFI, no, we are much tightening more, but here we are not more tightening. Suppose you more tightening, no, it is split out. So mild tighten, and then we again plunge that one, and then it is balanced.
Because it is sutureless, so it becomes very important that both the
Tightening is
knots-
very important, sir.
How many cases you have done?
7, sir.
And all are doing well.
Yes,
There
sir.
is no
Yes, sir. IUP also normal, sir, and cosmetically good, sir.
What is the time period for follow-up? Follow-up, how much time you have given for follow-up, ma'am?
Oh, sir. Follow-up, sir, 3 months, sir. I follow
3 months.
Through 3 months, every patient. But first cases.
Till
what-
3 months they were okay.
Huh.
So
And
this procedure has been started only 3 months ago?
No, sir, whatever procedure I did, 3-month follow-up, but first cases I did in 1 year back. So that patient is come to me, that is the 1 year. So
Okay.
other procedure is like 3 months, 3.5 month, 4-month follow-up.
So that 1 year patient, that is okay?
Yes, sir. First
I
patient
mean,
is okay, sir.
worries about the scleral side of that
Sir, actually,
dumbbell.
yes, sir. That is one I try many times, sir.
Yeah.
That I try that swing methods. So
Yeah.
that is I expose that area. Then
Okay.
suddenly I got that method. So that is why conjunctival peritomy is there.
Chalo, thank you very much.
Thank you. Any questions for the co-competitors? You can counter. Any question from anybody? Okay, so thank you,
Thank you,
Anjali.
sir.
Next is Dr. Avijit Paul. Is he here? Dr. Avijit Paul, rocking with her rock hard black cataract with mid dilated pupil.
A 75-year-old male patient presented with decreased vision left eye for 1 year. He had history of type 2 diabetes mellitus for last 20 years, for which he was on oral hypoglycemic agent. He also had history of benign hyperplasia of prostate, for which he was on alpha blocker. On slit lamp examination, there was nuclear sclerosis, grade 6 cataract along with mid-dilated pupil. The best corrected visual acuity was 3/60 in left eye. On specular reflection, there was no guttata evident. Posterior segment view was hazy. On specular microscopy, the CD count was 2578. Left eye phacoemulsification with soft shell technique along with use of BHEX pupil expander with a control of blood sugar under topical anesthesia was planned. A 2.8 mm temporal corneal incision was made. Trypan blue was injected to stain the anterior lens capsule and then washed. Dispersive OVD was injected followed by cohesive OVD to coat the corneal endothelium and to form the anterior chamber. BHEX pupil expander was placed with the help of BHEX forceps, dialer and Sensky hook. During the placement of last flange of BHEX, there was little bit difficulty, which was managed by retraction of iris with the help of dialer. Then a continuous curvilinear capsulorhexis of around 6 mm size was made. Hydrodissection was done gently, followed by rotation of nucleus. Pulse mode was used during phacoemulsification. At the time of sculpting, a linear central trench was made. The nucleus was rotated 180 degrees to extend the trench. Parameter used was torsional amplitude 70%, vacuum 110 mm of mercury, and aspiration 20 cc per minute. During job, the parameter used was torsional amplitude 70%, vacuum 550 mm of mercury, aspiration 36 cc per minute. Nucleus was chopped into multiple fragments and multiple strokes were done to separate the posterior plate. During quadrant removal, parameter used was torsional amplitude 70%, vacuum 600 mm of mercury, aspiration 40 cc per minute. At the end of quadrant removal, there was little bit struggle because the last two pieces were not separated fully. So then the two pieces were separated manually and the quadrant removal was completed. During quadrant removal, the assistant was instructed to give BSS at corneal wound to reduce corneal burn. After that, thorough cortical wash was done. Multi-piece intraocular lens was placed in the bag. BHEX pupil expander was removed with the help of dialer. Thorough visco wash done, and finally the wound was secured. Points to consider to deal hard cataract are proper pre-op assessment, grading of cataract, specular microscopy. If the endothelial cell count is less, it is better to go for small incision cataract surgery. Soft shell technique to be used, that means injection of dispersive OVD to coat the endothelium, followed by injection of cohesive OVD to form the AC. Pupil expander to be considered if the pupil is not adequately dilated. During chopping, multiple nucleus fragments to be made and care should be given to separate the posterior plate. Quadrant removal should be done in the bag or at the pupillary plane. Excessive use of phaco power should be avoided.
Nice surgery, Dr. Vijay. What was the indication of specular microscopy, because it is not available to all? Is it must?
Sir, to deal hard cataract like that, this if specular microscopy can be done, it's good to decide whether I will do phaco or if the count is less, directly considering small incision cataract surgery. But in some center, machines are not available. In such case, at least corneal reflection, which can be done with specular by our slit lamp machine, it should be done.
Yes.
What was the effective phaco time or total energy used, whichever machine you are used, and how it measures?
In this case, sir,
Energy, how much energy was used?
what I remember, sir, it's around 27. CD is 27.
Effects. Okay. And had you shown the first day post-operative picture, I would have given you more marks.
Yes, sir. It was good enough.
Thank you. Thank you very much.
Thank you, sir.
Call next paper.
Madam is asking
Hello?
question.
Doctor,
question.
one question.
Yes, ma'am.
Anything different you did in this surgery which you want to highlight here?
Sorry, ma'am.
Anything different apart from the small pupil with pupillary expanders? Anything different you did in this surgery which you want to highlight? Because it's a competition. What point you want to highlight in this video?
Because this is same procedure.
This is a routine
Yes,
procedure. It
routine
is not
procedure.
something different.
Not
Yeah,
something.
yes, ma'am.
It is done day in and day
What
out in
would you
all
highlight?
centers. What
actually-
point you want to highlight so that we can consider it for a competition?
Actually, ma'am, to deal such cataract, if we don't follow the proper way, it may lend it with many of complications. Like from the very beginning, like if we don't use pupil expander, that will create more problem. During chopping, there might be less separation, more energy might be used, which may be harmful for endothelium. And sometime if it is not been chopped and separated properly, there might be jonular dehiscence, might be nucleus drop and PCR. All these, all the kinds of complications may happen. So the message for this video is that if we follow the proper way, it will relieve us. It will relieve us from all these complications and stress.
Okay, thank you. Any other option for this we could have tried apart from for your concern about the endothelial count and all the stuff to prevent the complication?
Yeah.
Any other surgery would have been better because you were telling about SICS, right? Anything
Yes,
apart
yes.
from SICS you'd have thought about?
Apart from SICS,
You can try flax. No, no.
yeah.
If you have a facility of flax, I think that would be a better option since you are much worried about the endothelial count and the heart cataracts. Thank you, doctor.
Okay, thank you.
Next announce, please.
Stromal dissection, when type 2 bubble is achieved, is risky, especially with beginners. Deflating the type 2 bubble and proceeding with the manual dissection is a good viable option for beginner surgeons to prevent inadvertent rupture of bare desmet and thus conversion of dark to penetrating keratoplasty. Thus, it is important to modify the technique of dark on the type of bubble we achieve. One must always try to save the post-desmet for early visual rehabilitation and the immune privileges the patient achieves with DALK rather than converting it into penetrating keratoplasty.
Just wanted to know your Dr. Ankit. You are presenting on behalf of Ankit.
You yourself, Ankit, or you are presenting on the behalf of Ankit?
I'm presenting on.
It is
On the-
clearly
which is
mentioned. No,
clearly
the
mentioned.
presenting author should be present.
What's your name?
Rohini. Chief author is mine.
You are chief author, no? She is chief author. Rohini.
She can't be marked.
Rohini.
3972 है
Thank you, doctor. You just call upon the next person.
She is not rectified.
You,
Calling
but
doctor.
you are not a rectified member, AIOC. So you are not qualifying for the competition. Okay? You can present, but you are not a part of
Yeah,
that
you are not
competition.
ratified.
Okay,
Calling
thank you.
Doctor-
Next is tube trouble in a fragile eye. Dr. Wrinkle Goyal.
She's not ratified.
Summer sir, I think you can raise a voice for the video presentations that it should be in a hall rather than in a trade area, because lot of echo and it is difficult to hear. Speakers can speak because it is pre-audio, so it becomes more difficult. Sometimes we are not able to
In
hear
most
them
globe-
also. Okay, you can go for.
We can have a dance first and then we can continue the session. Typical Punjabi dance is going on.
Battlefield is the eye, but in this case, the fight extended beyond the In most glaucoma surgeries, the battlefield is the eye, but in this case, the fight extended beyond the operating room. Welcome to Tube Troubles in a Fragile Eye, tackling tube erosion in a high-risk patient. Let us meet our protagonist. She is a 57-year-old woman with multiple systemic comorbidities. diabetes, hypertension, and asthma, and a past coronary bypass for which she remains on aspirin. Owing to diabetic nephropathy, she is on regular dialysis, making her a very high-risk patient. Her ocular history is equally complex. She is a high myope with diabetic retinopathy, treated previously with panretinal photocoagulation. Additionally, she has primary angle closure glaucoma in her right eye after a failed trabeculectomy. An Ahmed glaucoma valve was implanted elsewhere. She presented with tube exposure and scleral thinning in the right eye, for which previously a scleral patch graft had been done. All this placing her at high risk of infection, hypotony, and vision loss. Considering the risk, we proceeded with tube removal. To restore ocular surface integrity, a Teno's patch graft was secured, supplemented by an amniotic membrane graft, reinforced with fibrin glue. Let us briefly look into key steps of the surgical procedure. Initial repairs appeared successful, fate had other plans. On the very next day, she returned with profuse ocular bleeding, marked lid edema, and a soft globe, despite anticoagulants having been stopped prior to surgery. It made us pause and ask, what truly went wrong? On further probing, she revealed a crucial truth. She had hereditary hemorrhagic telangiectasia and was given systemic heparin during dialysis right after surgery. What appeared to be a small detail had, in reality, derailed her recovery, a powerful reminder of the life-saving value of diligent history-taking. Given her fragile systemic status, surgical intervention was deemed unsafe. She was managed conservatively with antibiotics, tranexamic acid, bandage contact lens, and padded bandage. Over time, the blood clots resolved, but the episode led to conjunctival retraction and graft failure, ultimately resulting in a bleb leak with a Seedle-positive test. At this point, a second surgery became unavoidable. This time, however, the procedure was carefully planned in balance with a dialysis schedule, and anticoagulation was withheld. Intraoperatively, the leak had nearly healed. We performed conjunctival advancement with posterior relaxing incisions. Let us take a closer look into how the second surgery was carried out. Remarkably, with meticulous systemic and ocular co-management, her ocular surface integrity was restored without the need for a repeat patch graft. This case highlights how, in fragile patients, the alignment of systemic timing with surgical decision making can turn a high risk situation into a successful outcome. High risk eyes demand more than just surgical skill. They demand careful coordination with the patient's systemic needs. To conclude, treat the patient, not just the eye, because behind every eye is a life, a story, and a human being. Thank you.
Nice presentation. Did you keep the shunt again?
What? Sorry, ma'am.
The shunt was placed again?
Sorry, ma'am, I cannot hear you. Okay.
No, the shunt was removed. And
Yes.
how did you tackle the...
Ma'am, shunt was removed elsewhere. When she had presented to us, only the tube was there.
Okay.
The plate was not there.
Oh, only the tube was there?
Yes, ma'am.
Okay. So again, did you replace the shunt? Or?
No, ma'am. We just removed the tube because already there was a leak and the patient had visual prognosis was only...
So what was her IOP after the surgery? How did you manage the glaucoma?
Ma'am, her IOP was in low only because actually she had leak when she had presented to us, and then after that we had placed the graft. Then also that graft failed again because of the bleeding. So her IOP was low only. It did not rise after that.
Okay, thank you.
So you keep that tube place open. You have put the sutures on both the sides, but that tunnel was still open.
No, so the tunnel, it is the tube is just, we had entered into that place. So that there was just that one opening, hole.
So that opening you left
No, sir, that
same.
we had sutured with the nylon sutures, and then above that we had placed the
You put two
pneumonia.
vertical sutures
Yes,
like
sir.
this.
Yes.
So how can that cover and close that tube? Because it was a hole like this and you put two sutures like this.
So we just, above that hole we had sutured it.
Follow up, he is having a good
Sir, actually,
tension control.
the patient, because of systemic condition, she passed away. So at the 1 month follow-up, till when we had followed, she had good contact. There was no leak after that.
Okay, any question from the audience? Anybody?
Thank you.
Thank you.
Now I call upon Dr. Neha to present when LASIK gets lumpy, managing post-LASIK striae and epithelial ingrowth.
Gupta ji.
Yes, sir.
मेरी फोटो भेज देना.
हेलो.
आपके अब शुरू होगा दोबारा.
फिर से बुला.
फर्स्ट से.
वो जो पुरानी दवाई है वो ले सकते हैं.
Call next one, please.
प्रोग्राम चल रहा है.
So, Dr. Neha Pathak is here.
Yes, sir. I'm
Yeah.
here on stage. Yes.
Please start your talk.
Okay. Good afternoon, everyone. I'm Dr. Neha Pathak. So here we'll be talking about a young female, a bride-to-be, who underwent LASIK elsewhere 20 days back. She had few striae after the surgery, so the operating surgeon took her for a relift, hydration, but still the flaps persisted, the striae persisted, and there were a few nests of epithelial ingrowth also. So how we tackle this case, we'll see in this video. So first we are doing alcohol-assisted epitheliectomy. So epitheliectomy is important because it was an old case, 20 days post-op. So, and initially the surgeon also had tried removing the striae, but epithelium was not debrided. So meticulously epithelium was debrided over the flap and even around the flap area, because we wanted to make sure that the anchoring effect of epithelium doesn't make the striae recur or recoil back into their place again. Now we want to scrape off the epithelial ingrowth nest, so we lifted the flap and carefully scraped over the stromal bed and the undersurface of flap. double sure that we don't leave any epithelial nests behind, so we stained with a fluorescein stain for better visibility. And re-scraped. So now the second step in dealing such cases is to hydrate the flap with balanced salt solution, because it expands the flap and makes it more malleable. Then we stretch the flap with semi-wet cellulose sponges. Horizontal strokes are applied along the hinge axis and also radially to achieve optimal flap to bed apposition. We also use the Donenfeld method of heated ironing of the flap to completely remove the resistant striae. Again, we were careful that we don't dislodge the flap. We took a long time in dealing with this case. Surgery went over for an hour. We also decided to put sutures for two reasons: for prolonged mechanical stretching of the flap to avoid recurrence of the striae, and also to close any possible conduit for recurrence of epithelial ingrowth. I understand. I think I could have placed few more sutures for more even stretching of the flap, but these 3 sutures also worked very fine for the patient. This was the post-operative day 1 picture in retroillumination. The striae had gone. There were no recurrent epithelial ingrowths. 2 months post-op, she had 6/6 vision. Perfect vision was restored just in time for the bride to walk down the aisle. Thank you.
Thank you, doctor. Thank you, Dr. Neha. It was a very good presentation.
Thank you, ma'am.
How much percentage of alcohol, because absolute alcohol we can use in the, so how much percentage of that alcohol
Sir,
you
it's
use?
20%, sir.
20%?
Yeah.
Okay.
1 ml alcohol and 4 ml saline or
Okay.
BSS.
What is the incidence of stria in your cases? How many cases you have operated and how many times it had to be done? I mean,
Sir, actually it was from outside of our hospital. Our hospital, actually we are doing LASIX very less. We have a smile platform at our place.
Okay.
So at our setup we are not seeing practically any cases. This was from somewhere else, in Jaipur only, but from outside our hospital. And I even talked to the person who had operated, so probably because of the hurry in which they closed the case, this thing happened. So after repositing the flap, after finishing the LASIK, probably there was a bit of a hurry, and she's actually a friend of mine. So we had a candid chat about this case, so probably that was the reason that the flap slightly slipped out of the place and a striae came.
So what is your take-home message from this presentation?
I want all the refractive surgeons who are beginning basically to be extremely meticulous and have patience while doing this surgery, because it is a precision surgery. So when the risk factors can also be a prolonged duration of surgery, and if there are high refractive errors which we are correcting, then there is a lot of flattening of the stromal bed. So there is a mismatch between the curvatures of the undersurface of the flap and the flattened stromal surface. So that mismatch also can lead to striae, but that is not in our control. So we should try to finish the case on time, but after repositing the flap, we should be patient and see that whether the edges of the flap are perfectly aligned with the epithelial ring. And even after that, 1 to 2 minutes we should wait, and we should do a striae test intraoperatively, where we press the periphery of the cornea using a blunt instrument like the back of a cellulose sponge, and then we see the radial folds are transmitting without any break along the periphery of the flap rim. So that would mean that the flap has perfectly adhered to the underlying stromal surface, and then it is safe to close the case.
After
When did the patient come to you? After
It
how many
was
days
20 days after the operating.
And the patient didn't get vision? I mean, right from the day one, she was having stress?
She was having trouble, and the operating surgeon had tried to relift and massage on post-operative day 1.
So when did the surgeon check her eye? I mean, how much
Next
time
day.
after the
Next
surgery?
day. Next day after surgery.
Means he consulted
Next day.
post
And the
operatively
stress were there.
Stry were there, and then the same day she took the patient again for relifting of the flap and massaging of the flap and hydration of the flap, but she didn't do epithelial debridement.
No, next day, I mean, epithelial growth had occurred in one day only.
So epithelial ingrowths happened after the second procedure. Because probably the epithelium was not debrided and we entered the flap area. From that area, epithelial nests enter the interface.
No, once reopposing the flap, suppose should have washed and wait for thoroughly under the flap. That's
Yes,
one
sir.
important
Yes, ma'am.
step
Yes,
we
ma'am.
have to follow, right?
Yes,
So we have to
ma'am.
thoroughly wash,
Yes,
reoppose
ma'am.
it, see for the alignment, wait
Yes,
for some
ma'am.
time, and then we go for the other eye.
Yes, ma'am. Thank you so much, ma'am.
I think the frequent follow-up of these cases is very essential. And when this surgery is done, every time we should not ask the patient to go home just after that. We should wait for some time, 20, 30 minutes. And that is the most important examination.
Yes, sir.
The carry-home message is this.
Yes, time being
Sorry, I missed saying that point,
Yeah.
sir. It's
Is
very
it a high
important.
volume center for doing LASIK?
On confocal microscopy, it has been seen that it is present in 97% of the cases.
Yes, sir.
But
They are
of
micro.
course, we have to do intervention in just 1 to 1.5% of the cases.
Yes, sir. Yes, sir.
So all these cases should be meticulously seen, and if there is a problem, I think immediately the thing should be taken care of.
Yes, sir.
Because this is otherwise gives a bad name to our ophthalmologists.
Yes,
Because patient is all absolutely seeing well,
Yes,
and after doing the procedure, if he or she doesn't see well,
Yes,
so
sir.
that blame comes to all of us.
No, one thing I'm curious
Okay,
is why
thank you
did she
very
attempt an
much.
epithelial debridement?
Any
Why did she
presenter
refer
who
to
has
it?
joined late and
Sir,
not
ma'am, no
presented,
idea,
sir, your name?
Thank you so much.
I'm repeating the names again. Pradhanya Vasule, is she here? Pradhanya? No. Rakesh Gupta, sir, please come. Mini whale phaco, a novel double tunnel technique for a small pupil using DRG chopper shields. Rakesh Gupta.
A small non-dilating pupil is a common challenge for cataract surgeons. Multiple techniques have been described to address this, with the most widely used being iris hooks or pupil expansion devices such as the Malyugin ring, B-hex ring, or Gupta ring. These devices have been in use for years, offering greater safety and predictability during surgery. This video demonstrates a novel technique for managing cataracts in a small non-dilating pupil. The approach involves creating two phaco tunnels and, after performing the capsulotomy, removing the cataract by alternately using both tunnels and switching hands. The principle behind this technique is direct accessibility of phaco fragments from diagonally opposite end, which makes it easy to hold or chop or emulsify the phaco fragments without damaging iris and/or capsule. Two tunnels in opposite half of cornea makes it possible. This technique is further enhanced by the use of the DRG chopper shield designed by Dr. Rakesh Gupta. Let's see the videos. First video is a case of complicated cataract with small pupil and posterior synechiae. We begin by creating the right-sided main tunnel and initiating the capsulotomy. After OVD injection, a 360 degrees synechialysis is performed to release the posterior synechiae. Using microforceps, the capsulotomy is completed, deliberately made slightly larger than the pupil to improve access. Hydrodissection reveals a soft cataract, which can be difficult to rotate. Here, the DRG chopper shield is used to protect the iris margin and anterior capsular edge. To improve maneuverability, a second, left-sided tunnel is created, allowing approach from the opposite quadrant. The soft lens matter is gently aspirated. Here, the DRG chopper shield is used to protect the iris margin and anterior capsular edge. Bimanual irrigation aspiration of epinucleus and cortex from both visible and hidden areas. Hydroimplantation of a foldable acrylic IOL is performed. And viscoaspiration completes the procedure. Post-operative day 1 shows a quiet eye, a well-centered IOL, and no evidence of iris trauma, capsular tear, or retained fragments. No swatch, second video. This is a case of senile miosis without posterior synechia. After creating the main tunnel superotemporal in left eye, the anterior capsule is stained with trypan blue dye, carefully injected beneath the iris for uniform staining. Capsulotomy is performed under OVD using a 26-gauge bent cystotome followed by hydrodissection. OVD is re-injected and the nucleus is rotated. This case features a grade 2 to 3 nuclear sclerosis, providing good rotational control. The DRG chopper shield, with its 110 degrees angled, bulb-shaped tip, is then glided under the iris and anterior capsule. The handoff tip allows ramp walk of iris and anterior capsule over the DRG chopper shield.
This is going, continue, it's after this.
Not visual, video.
Capsulotomy is performed under OVD using a 26-gauge bent cystotome. Aspiration clears the cortex completely. Two strategically placed tunnels in opposite halves of the cornea allows is performed and ports are hydrated to conclude surgery. Conclusion. Using two strategically placed tunnels in opposite halves of the cornea allows complete and safe cataract removal under the iris without a pupillary expansion ring, minimizing trauma and maintaining surgical control. DRG chopper shield not only performs safe horizontal chopping in invisible areas but also guards the iris, capsule, as well as manipulate nucleus and epinucleus towards pharcotip.
Sir, the tunnel on the other side, you use which hand, the dominant hand or the non-dominant hand?
So, actually, I have developed ambidexterity, so I am switching my hands alternately.
You are ambidextrous?
Yeah.
You are right-hander.
So, I am actually right-handed, but I have acquired ambidexterity, and now I am able to use both hands in phacoemulsification.
Because in the initial
But
stage,
generally,
very
most
difficult.
of the surgeons would not be able, might
able
not
to
be
do.
able to do that.
Yeah, so, ma'am, yes, if in this, like I have been I've been practicing 20 years as a right-handed surgeon, but last 5 years I have converted. So this is one message that if we use our left hand more often, it is trainable. So I trained my left hand at the age of 45.
I understand, sir, but what my suggestion is, since you are doing a good hydrodissection, whichever area you want to chop, you can just rotate and bring it to the phaco tip and you can chop,
Yes.
right? Isn't that possible,
so
sir?
that is quite possible. So like, even in posterior polar cataracts, when there is no hydrodissection or delineation possible, so I'm using this technique.
So
I expanded this to the small pupil also. So I'm practically not using these pupil expanding rings in more than 70% of small pupils.
And the instrument you use, you can do with the sharp chopper, or you can do, that is okay. Nothing, no need.
What is DRG chopper shield has helped in this surgery?
Chopper
the topic.
shield, what
Yes.
does?
So if you see this chopper, it has a blunt tip at the end.
Okay.
It has a 100-degree angle also.
Okay.
So the outside is completely smooth.
Okay.
So it has a 2 mm long tip. So if you keep it, it actually holds the iris in a way that even if there is, iris will come towards, so it will come above the chopper, it will not go towards the phaco tip. So it prevents the iris chafing. It also, this tip is below, so it also prevents sudden, if there is surge, so it will also protect capsule also. So there are other videos, like this is only for small people, so actually I have submitted 3 videos.
You should have focused it for some time.
Yes.
Everybody,
No,
everybody
so
to
when
see.
you are using it as a shield, you are not using it as
It's
a chopper.
I mean, very good thing. Yeah.
So
that
when you are
have told us.
chopping, then you need to chop.
Yeah, so it is
we cannot
chopping.
hold the iris. We cannot perform the two things together.
No, sir.
This is what special chopper is. Yeah, this is what your
So
special
it is
chopper
horizontal
is.
chopper, so when I'm doing it, so iris is
allowing.
like this. So when I'm chopping it, it's actually chopping it, and it is also protecting iris.
Absolutely.
Only you are rotating with that chopper. That is the main thing that you have disclosed it. That is, you can do with the other chopper also. And I think expander may be best, but we can do with this.
Yeah, it's possible to do, but it's
Definitely.
safer with this.
Yes.
So it's a modified.
Only right hand person can do easily. Rotate the nucleus, again bring it front, then again rotate, bring it another part. That is very easy. No need.
I think the best plus point of his is that he is ambidextrous.
He's ambidextrous.
Which has been, I had looked for the literature.
No, most
the
of the
15% of the people, I mean the surgeons, they are ambidextrous.
I am also left-handed surgeon. I have also learned right side, and I think sir is also left-handed surgeon.
There are so many surgeons who are doing this. So if we use in phaco also, like retinal surgeons
Yeah,
are
yeah,
ambidextrous,
absolutely.
corneal surgeons,
Absolutely.
but in phaco, people don't try. So if they try,
You will have to teach us. You will have to bring into your club more people who can do.
So it definitely is a big help. It's a big
Secondly, Dr. Bhattacharya may not be annoyed with you. You are not using his.
It is just like that left-hander bowler can be a right-handed batsman.
Nice
Ravi Shastri.
video. Yours very good idea. I mean,
It's a
that's
very good innovation, but I'm not doubting whether most of the surgeons will be able to do it or
And
not.
one more
It's-
plus point, you acquired it at the age of 45.
So that
I
is the
mean,
message
everybody can do it. If,
So exactly,
if you wish.
that is the point. It's acquired. It can be trained. Like your
Yeah.
left hand can be trained, and it is also almost 90% trained. For example, I always say if you are using chopper with the left hand, which needs more maneuverability, but people they simply don't go beyond that. If you hold your phaco handpiece in the left hand, then the left hand is the hand which is holding doing chopping movements. It is actually trained. So it's just if you convince yourself, you switch your hands. In few cases, you will realize that you will be working in 360-degree field.
No, this is the first time I'm seeing something like this. That's
It's
why I was wondering.
coming to my mind about the cricket. Lala Amarnath had two sons, Surinder Amarnath and Mahinder Amarnath. He made one right-handed and the other left-handed.
Most of the
And
small
both
pupils,
were,
if
both
it's
were adjusted in the team.
Mahendra Amarnath was the man of the series in the World Cup 1983.
Absolutely.
small pupils, if it's
Just
not
on
a
the
very
lighter
soft
side.
cataract, I think it's better to do a vertical chopping rather than a horizontal chopping.
Thank you,
So
Dr.
this is the advantage of this chopper. It just slides.
If it's
a
very
blind
soft, it is very difficult to do a vertical chopping.
So I'm doing it even 4+, 5+ cataract also, even small people. So there are more videos, but I think short of time.
One still of magnified chopper's picture was needed in this.
So it's there in the video actually. It's a magnified.
So it was very fast going on, so it was not visible.
Yeah, it's
a still photograph.
Next
was
time,
needed.
whenever
Thank
you
you,
show,
Dr. Gupta.
everywhere, I think
Any
focus
late
it, I
presenter
think
present here? Anyone? Oh, Dr. Last call for Dr. Pradanya, Dr. Nikita Balani, Dr. Saurabh.
Patwardhan.
Anybody?
Dr. Saurabh Patwardhan.
You are?
Patwardhan.
Yes, madam. Shefali. Which one? Doctor?
Yeah, you are Shifa Sheikh. Yeah, sure.
Okay.
You are allowed.
Okay.
Go ahead.
Indications of pupilloplasty. Dr. Shifa Sheikh. And anybody present, this is a last call, then we are going to close it.
Good afternoon, everybody.
Dr. Shifa Sheikh, indications of pupilloplasty.
This is a video showing indications of pupilloplasty. Four case scenarios in this video and how we have managed every case. First case is a 10-year-old male patient with minus 10.5 diopter myopia, best corrected vision of right eye 6/6 and left eye 6/12 parts. On examination, right eye showed within normal limit and left eye was having iridofundal coloboma and lens opacities causing glare and disturbance in vision. We can see coloboma with soft cataract. So we decided to do cataract extraction followed by IOL placement such that haptics are placed in colobomatous area. Now, second step is doing pupilloplasty by using single pass 4-throw technique. We are using 90-Prolene and 25 gauze and grasping forceps. Now, we are going to guide both the 25 gauze needle as well as the Prolene needle, and by doing railroading, we are moving further. Now, we are taking the loop outside. This technique is known as the single pass 4-throw technique. As the loop is taken out, we are going to pass 4 throws from the cut end of the suture. We are using micro instruments. Now slowly by McPherson, tighten the knot very slowly and gently. We have to tighten the knot not to be too harsh. Now we are going to continue the same procedure by doing one more knot so that the gap of the coloboma is closed further. Slowly tightening the knot by McPherson. Post-op, the vision is restored of the patient. Second case is a case of post-traumatic aphakia with fixed and dilated pupil. History of trauma was there, followed by cataract surgery, probably subluxated, so patient was left aphakic. No BC support. So first we decided to do pupilloplasty. As we can see, loss of iris superiorly. It was done by single pass 4-throw method. A 25 gauze and grasping forceps was used to guide the Prolene needle, and on the other hand, it was braided into the 25 size needle by the standard railroading technique. As the needle is passing by the bore of the 25 gauze needle, it was withdrawn. Then a loop of 90-Prolene suture was pulled out of the side of the incision. The tip of the suture is threaded through the loop, and 4 times we are going to pass through the loop. So here we can see the 4 throws are going through the loop. Now we are slowly pulling both the ends so that the knot slides over the suture and followed by iris claw lens placement. This is a pre-op and post-op picture, restoring vision. History of hit by stone in left eye since 15 days ago. Best corrected vision right eye 6/6 and left eye counting fingers. On examination, right eye was within normal limit and left eye was having traumatic mature cataract with 2 hours iridodialysis with secondary glaucoma. IOP was 16 in right eye and 39 mm of Hg in left eye. As we can see here, we are having mature cataract along with synechiae in this patient. So we decided to do lens aspiration first along with synecholysis. Now slowly we are breaking through the synechiae as seen in the video. Now we'll be starting to doing the capsular rhexis, followed by the aspiration of the cataract. Now we'll be placing the IOL in the back as seen in the video. The next step will be doing pupilloplasty. We are doing pupilloplasty by using 90-Prolene needle and 25 gauze and grasping forceps. This method is known as single pass 4-throw technique. Slowly, we are passing the proline needle to the other side. Now, we are going to take out a loop, and by fourth rows, we are going to continue. Fourth case is a case of cataract with extreme eccentric pupil. 60 years old female patient with a history of childhood trauma since her vision was subnormal 20 by 60. Further deterioration of vision was noted due to cataract. Undilated axial length could not be measured with dial master as the optical center was covered with iris, so dilated biometry was noted in this patient. As we can see, toric IOL was required to correct the astigmatism. So we ordered a toric IOL. Now let's think. We have to start with putting iris hooks, followed by phacoemulsification with toric IOL and pupilloplasty. So first, we are going to mark the cornea for the toric placement, followed by 2 iris hooks to retract the iris. Now the pupil is dilated enough to do the phacoemulsification and placement of toric IOL. This is the optical center of the eye. The next step was to make the pupil more center. It is done by using unipolar diathermy, in which heat energy is produced, causing shrinkage of collagen in iris, leading to retraction of radial fibers and to retract the iris from center. Now we can see that the optical center is uncovered and iris is dragged on one side. By blue dot we can see that the optical center is marked and some more diathermy is done. Now we are going to do pupilloplasty using the single pass 4th row pupilloplasty using the 90 proline and 25 gauge N grasping forceps. We can see post-operative day 1 and now after 1 month vision is 20/20 and patient was happy. Take home message is pupilloplasty is done to repair or reconstruct a damaged and abnormal shaped pupil. In all our cases we have done it by single pass 4th row technique so that the patient's vision is improved and addressing the associated cosmetic concerns.
Very nice presentation, doctor.
Yeah, are these 4th row pupilloplasty procedures, they are reversible somehow? Suppose the patient gets retinal detachment, especially when we make it a pinhole pupil, that vision becomes very good, that's a nice thing. If we have to treat retinal detachment in such cases, so what is the alternative? Anything you have thought about?
It will be very little difficult, sir, if you are treating such patients.
You can speak loudly. Everybody listens.
It will be little difficult if the same patients gets retinal detachment.
Pardon?
It will be little difficult if such patients get retinal detachments.
Yeah. If the patient gets retinal detachment in such cases in which we have made a pupil very small, like in pinhole pupilloplasty what we are doing.
Yes, sir.
So what can we do? How to do the surgery? I think we can recut.
You can cut the sutures.
And again do pupilloplasty. Yes. Yeah. So nicely presented.
What was the
It's a good
diathermy you were
procedure.
doing, doctor?
Yeah.
Can you explain?
Very nice.
The diathermy you are doing, no?
Hi, so it was a unipolar diathermy. So we are using this thermal energy.
What diathermy is it?
So we have to we are going to put direct the probe on the iris, mid periphery iris, which contracts the iris and will pull the iris to the periphery so that we will get the pupil in the center.
It won't burn the corneal entry.
Yes. It will thermal energy will be there, but very low. That the low thresholds will be used, like 60.
By which method? By which method?
Sorry, sir.
By which method you are going the thermal cautery?
This unipolar diathermy. This thermal energy will be used.
Bipolar cautery.
Unipolar.
No, that unipolar, sir. Thank you.
Thank you. So it's a last call for Dr. Pradhanya, Dr. Nikita. So that's all. I will ask and request all the presenters, Basat sir, please come for a group photograph. All the presenters, please come on the stage for a group photograph.
No, sir.
Chalo. Yeah.
You see, for all juniors, those who are presenting in a video or any forum, these ultimately uploaded in YouTube, and it is available ultimately to everyone. So when you are showing some complication like that, bleeding, and you are telling that we have missed the history of heparin and all these things, probably that is for our reason. We have to safeguard ourselves also. So you must be cautious about giving a statement like that, that we have forgotten to take the history of heparin. That's why that bleeding happens. So that might go to long way actually.
Legally, you have accepted your fault.
Yeah,
In public.
don't disclose in this is a public forum now.
In public,
it is not a scientific program. It is a greater public forum.
Absolutely.
So anybody can download your
Yeah,
video.
very good point. I think everybody should keep in mind.
Yes.
Yeah, nice.
Yeah, it's my turn.